Hello, everyone. My name is Catherine Collins, and I will be presenting on the Big Bang Children's Medical Center case study. The Big Bang Children's Medical Center is a 187-bed tertiary care center that serves pediatric patients from the local area as well as international patients. The particular problem for this hospital is the issue with patient and parent pain satisfaction scores. So these unfortunately have been decreasing in the past fiscal year. They've gone to less than the 40th percentile in the last quarter, whereas the hospital itself had been previously ranked in the 90th percentile for, quote, quality, service, and patient satisfaction. In terms of the task force that was put together in order to combat this problem, there are the co-directors, Penny, who is a clinical nurse specialist who was recruited to help look into this particular problem, and then Dr. Leonard Hofstadter, who is a pediatric anesthesiologist. Those are the co-directors of the pain management team. There are some other members. Amy Farrow Fowler, she's the charge nurse and manager for the surgical orthopedic floor. Dr. Stuart Bloom, who is the chief medical officer. Leslie Winkle, who is the CEO. Sheldon Cooper is the chief surgical officer. Bernadette Rostenskowski is the pharmacy director, and then Raj Kuthrapali is the chief nursing officer. And then there is, of course, myself, Katie Collins. I am a nurse practitioner. The specific goals for the task force that was formed are listed here. So the first one is improving pain management perception/scores for the Children's Medical Center. Second is developing a 24/7 referral service that can be used by healthcare providers, patients, or families to report underreported pain. This consult service would include a patient assessment and implementation of a treatment plan within 2 hours of the report. And then finally, the last goal for the task force is to collaborate with key stakeholders to promote agreement about effective pain treatment. And I will be discussing the Berwick and the Fish models in terms of what model was utilized in order to achieve these goals. On this slide, I will be discussing the Berwick model. This model was created by Dr. Donald Berwick, who was previously the president and CEO of the Institute for Healthcare Improvement. He also worked for the Centers for Medicare and Medicaid as well under the Obama administration. In terms of his model, essentially what this model is trying to do is allowing for a team or a group of persons to work together towards a common goal. The model includes rules for effective change and then also for resilience within an organization. So a portion of Berwick's model includes 7 rules. First rule is to find innovations that are sound. Rule number 2 is to find and support the innovators for that rule. Rule number 3 is to invest in early adopters. Number 4 is early adopter activity must be observable. Number 5 is to trust and enable reinvention. Number 6 is to create flexibility to allow change to occur. And then finally, number 7 is leading by example. That is a portion of Berwick's model. The other, another portion of the Berwick model is includes 4 properties of interaction between patients and their care team. So the first is regarding information transfer as a key form of care between the healthcare team and the patient themselves. The interactions between the healthcare team and the patient, these should be tailored based on the patient's needs. The third property is that patients should be the source of all control, given that it is their care that is being given. And then the fourth property of interaction, according to Berwick, is that interaction should be transparent. So that, again, is the Berwick model that we will be discussing further in the future slides. Another model that was considered but ultimately not used for the change that was needed at the health center was the Fish model. So the Fish model, essentially, it was adopted as a kind of a fun and creative way to foster camaraderie among a team. Essentially, the idea behind it was to establish a common goal for this team, and then utilize things such as fish rewards, fish stickers and magnets, and stuffed animals in order to motivate a team to achieve a desired goal or a desired behavior. Essentially, this model was not chosen to help implement the change needed at this health center. And the Berwick model, which was discussed in the previous slide, was ultimately utilized for our purposes of implementing a change at the Children's Health Center. Okay, so now I'm going to be talking about the work plan that we implemented in order to achieve the set goals that I discussed above that the task force put out. The work plan that we utilized was divided into 5 steps, and it should be noted that in all of these 5 steps, the properties of interaction that was established and discussed earlier by Dr. Donald Berwick were utilized. So again, I want to go over these. They were regarding information transfer as a key form of care, tailoring interactions between patient and healthcare provider based on the patient's needs, patient being the source of all control, and then interaction between the healthcare provider and the patient should be transparent. So again, this was divided into 5 steps. So step 1, we found innovations and innovators to support improved pediatric pain management. It should be noted that I will be discussing further details of each of these steps in future slides. Moving on to step 2, implementation of a 24/7 consult service was completed. That included a patient assessment and as well as implementation of a treatment plan for pain within 2 hours of a report with the application of trust between provider and patient, and then as well as reinvention of the outdated patient assessment technique at BBC-MC. Step 3, we allowed for observation and investment of early adopters of the new services, along with utilizing a new pain assessment tab with the electronic charting system. So again, those coming later to the task force and the implementation of the new changes were able to view the early adopters, what they had done previously in the electronic medical record, specifically under that tab. So that really helped utilize that helped these later adopters to observe what had been done by those early adopters. So step 4, we created flexibility with the new plan to help facilitate this change, as well as to aid in motivation of team members to complete the adopted changes. So roll kind of with resistance on that part. And then step 5, of course, we utilized the leading by example. Those that were the early adopters that initially had implemented these changes were continued to do so moving forward. Okay, so details on the first step of the work plan. Again, step 1 included finding innovations and innovators to support improved pediatric pain management as reported by patient and parents. Key players were Penny, Dr. Leonard Hofstadter, Amy Farrah-Fowler, Leslie Winkle, Stuart Bloom, Sheldon Cooper, Bernadette Rostenkowski, and Raj Kuthrapalli. The barriers to this specific plan that was implemented included an unwillingness on part of the nursing staff as well as the CNAs to implement new changes due to a lack of familiarity with proposed changes, also due to high staff to patient ratios. Other barriers included lack of interest or incentive by staff to take part in the brainstorming techniques to help improve patient pain scores, and also, again, lack of interest or incentive to attend training for new changes. The resources that were necessary for this particular step were the key players listed above, who I've listed off, the funding that was needed for the trainings, as well as the informational handouts, the EMR system, and the IT with the knowledge of how to fully utilize this system, as chart audits were necessary on both pain management and on satisfaction scores. So the methods, so essentially the task force devised a solid plan for this step, and then they implemented 12 separate mandatory training sessions of approximately 60 to 90 minutes in length that helped facilitate staff involvement. And these mandatory training sessions also allowed for concerns and recommendations to be voiced by the staff attending. After these mandatory training sessions were completed, handouts were released that contained necessary information on implementation of the proposed plan, including both nursing education, on appropriate pain assessment tools for different age ranges, as well as pain reassessment. And all questions and concerns by the staff themselves were voiced and addressed in this step for what we have talked about. Okay, so for the work plan, step 2 of the work plan, which was implementation of a 24/7 consult service that included a patient assessment as well as implementation of a treatment plan for pain within 2 hours of a report, including the application of trust between provider and patient, and as well as reinvention of the outdated pain assessment techniques at the medical center. So in terms of this step 2 plan, the key players were Penny, Dr. Leonard Hofstadter, Amy Farrah-Fowler, Bernadette Rostenkowski, and Raj Kutharpalli, as well as myself, Katie Collins. The barriers, there were a few. Funding for the consult service was definitely a large one. Lack of standardized protocol for pediatric pain management was certainly one as well. And then familiarity with outdated pain assessment techniques by staff was a difficulty to overcome in this step. The resources for this step 2 included the key players listed above, funding from key stakeholders, the staff willing to work for the consult service, and then research on best pain management protocols for pediatric patients. In terms of methods, Dr. Leonard, Penny, Bernadette, Raj, and myself all assisted in development of a standardized protocol for pain management, as well as the initiation of this 24/7 consult service. Amy Farrah-Fowler created educational sessions for staff members who were part of the consult service, as well as for the protocol for pain management assessment and treatment. And this included what is ordered, and pointed out that the plan must be initiated within 2 hours of report. Last but not least, there was some education provided to the staff on motivational interviewing and rapport building techniques, mainly to assist in trust building between the healthcare provider and the patient themselves, to go along with that Berwick model we discussed earlier. The third step that was implemented for this particular work plan was to allow for observation and investment of early adopters, along with utilizing a new pain assessment tab within the EMR system. So the key players were Penny, Dr. Leonard, Amy Farrah-Fowler, Leslie Winkle, Dr. Stuart Bloom, Sheldon Cooper, Bernadette Rostenkowski, various nursing staff from different departments, and then Raj Kutharpalli. Barriers to this particular step included lack of interest to become an early adopter and unwillingness to change current practices by nursing aides as well as RN staff. Another barrier was perceived lack of charting time to complete this added tab of information on pain assessment and unfamiliarity with the new EMR tab. The particular resources were those key players listed above, as well as the nursing staff who was willing to become early adopters of the new techniques. And finally, the EMR IT staff that provided education to the nursing staff and aides on how to utilize this new system. So in particular, Amy Farrah-Fowler and Raj Kutharpalli, those two were the main forces of the key players here behind this step. So those two, along with a handful of nursing staff, became early adopters that were then observed by other staff members. The IT staff, as I said above, provided education to all staff, part of this initiative, on the use of the new EMR system protocol. Okay, so step 4 is to create flexibility with new plan to facilitate change and aid in motivation of those team members to complete these adopted changes. The key players were the same as listed in step 3. The barriers to this particular step included lack of flexibility in those team members resistant to change, as well as understaffing or lack of interest in the nurses and other staff, including consult service members and providers. Resources included those key players listed above, flexible team members, funding for incentives provided to those staff who were flexible and took part in pain management initiative. And then I wanted to note, according to an article by O'Kello and Gilson in 2015, motivational factors for healthcare workers include respect, recognition, appreciation and rewards, supervision, teamwork, management support, autonomy, communication, feedback, and openness, staff shortages, and resource inadequacy. The methods for this step, all task force members and various nursing staff were the major players. As stated previously, Amy Farrah-Fowler and Raj Kutharpalli were essentially the driving force behind the recognition and incentives for those team members that showed flexibility with the new plan implementation. And it should be noted that both financial and non-financial / recognition incentives were provided to flexible staff members to help facilitate this step of the work plan. So the final step in the work plan, step 5, was leading by example. Key players in this step included all staff involved in the initiation of the new pain management protocols, including all those listed in the previous steps. The barriers included lack of leadership or involvement by those in leadership positions, understaffing of the nurse and the providers and those in the consult service, lack of interest in changes by these staff members, and then lack of flexibility with these changes. Resources for this particular step included all the staff that was willing and flexible with the new changes, including those listed in previous steps. Other resources were updated protocol handouts to be provided for those who needed refreshers or further training on the new implementation protocols. Funding for staff trainings and for staff incentives was also a resource, and then chart audits to examine the patient satisfaction and the pain assessment. The method, so all those involved in the new pain management changes were given the opportunity to ask further questions and to give feedback on the new changes that had occurred, as well as any further changes that could potentially improve the new system. Again, staff was provided with financial and non-financial incentives for taking part in this new initiative and for providing further training and clarification for any staff member that still required it. Okay, in terms of outcome, the policy was created over a 4-month timeline, which allowed for adequate time for staff to both research and learn new protocols, as well as for the development of the consult service, the 24/7 service that we discussed earlier. This period of time also allowed for staff to get used to completing the pain assessment and reassessment, as well as the use of the new EMR tab on the pain assessment. Data collection on pain assessment and perception of pain assessment and management by patients and parents was collected 6 months prior to the start of this new initiative, and this data is continually monitored on a quarterly basis moving forward. Other data that is monitored biweekly is auditing of the nursing charts to ensure compliance with new protocols. The goals, again, kind of listed above, same thing, the initiative of a pain treatment plan to improve reported pain scores by patients and parents. This plan involved the input of key stakeholders, and a 24/7 consult service was completed that performs patient assessment and implementation of pain management within 2 hours of report. Okay, so the outcomes continued. So the short-term objectives of this initiative is to survey every patient and parent for satisfaction of pain management. Ideally, this will be completed on every patient and parent by September 1st, 2019. Pain scores and medication protocol will be individualized to each patient and will be noted in the patient's room on the whiteboard by November 1st of 2019. The midterm objectives, all staff involved in the new initiative will complete training by August 15th, 2019. These trainings will include information on the following pain scales: the Faces, Legs, Activity, Cry, Consolability Revised Scale, the Faces Pain Scale Revised, and the Numeric Rating Scale. Every nurse will then be evaluated for appropriate use and knowledge of these scales. Pain will be reassessed by nursing staff within 1 hour of administration of a pain medication, and this compliance, which will be assessed with chart auditing, will be about 100% by December 1st of 2019. Okay, so the long-term objective of this entire initiative overall is to increase pain treatment scores as well as patient and parent perception of pain treatment to greater than 90th percentile by June 1st, 2019. The outcomes of this initiative are all towards the common goal of improving pain management at this medical center. Now, with the utilization of the 4 properties of interaction discussed earlier by the Berwick model, including transparency in patient and parent interactions, tailoring these interactions based on the individual needs of the patient, allowing the patient and parent to be a source of control, and utilizing communication as a form of care, these specific outcomes will be achieved and potentially even exceeded. And these specific tenets of interaction established by the Berwick model will be utilized throughout the entire work plan and training process with all staff members, as well as encouraged in staff and patient and parent interactions moving forward. All right, so as you'll see here, I put the definition of interprofessional teamwork. according to Eggenberger, Sherman, and Keller. So essentially it refers to the cooperation, coordination, and collaboration expected among members of different professions in delivering patient-centered care collectively. So as you can see throughout the initiative, the discussion of the initiative, it clearly supports the use of an interprofessional team, as staff from multiple professions were included, so nurses, nursing aid, IT staff, providers, administration, stakeholders, those working for the consult, 24/7 consult team, patients and parents themselves are also part of this initiative. So essentially, again, it greatly supports and fosters the use of interprofessional teams. The other thing that will be implemented, so in addition to the initiative itself, there will be evaluations completed by designated persons from each department or specialty. So for instance, there will be a anesthesiologist, there will be a nurse from each floor, there will be an administrative person, an IT person, stakeholder. All will be involved in a monthly meeting where they will evaluate how the initiative is going and any concerns or thoughts from their particular specialty or area of expertise, to again further foster that idea of interprofessional teamwork. Okay, just to talk a little bit about advocacy, in particular in regards to pain management in this particular initiative. So there's individual or patient advocacy. So the patient and their parents may advocate for themselves by completing surveys of perceptions of pain management after their stay, as well as by speaking up when there are any questions or concerns that arise during their stay. They may suggest alterations to the current approach that may help them or other patients at a future stay at this medical center. Other type of advocacy that can occur is health center employee advocacy. So this includes all staff members involved in patient care at this health center. These staff members may advocate for the rights and well-being of each patient and should voice any questions or concerns about the initiative, most especially if it may compromise patient care or decrease patient pain management satisfaction. Employees such as nurses and providers may advocate for decreased use of narcotics as appropriate and advocate for more holistic pain treatment approaches moving forward. Just a little bit more about advocacy. So the hospital can advocate, the administration may advocate for the proposed improved pain management initiative by sharing information to the general public on the new changes, including through the use of social media and email. The hospital may also allow for public feedback on the new initiative, as well as other pain treatment approaches. And then lastly, on advocacy, political advocacy. So hospital employees, as well as patients and parents, can advocate for improved pain management across the country by discussing with local political officials and by voting for those officials that support appropriate pain management measures. So in terms of next step, so just as you can see here, so far the Pain Management Initiative has shown a trend in increased reported pain management scores from parents and patients themselves at the medical center. So this program will continue as long as scores increase, and any necessary changes will be implemented to further improve this initiative. Next steps include identifying areas of weakness in the initiative. This will be completed by chart audits of individual staff members and allowing for anonymous comments on the initiative and on concerns or problems that have arisen since it started. Concerns will be discussed at each interprofessional meeting, which will be held at least monthly, and appropriate changes will be made based on these discussions. Other information that will be discussed at these meetings will be any new research on appropriate pain management protocols and appropriate ongoing education for staff members. The last step will be to have monthly training classes on appropriate pain assessment for those staff members who will be completing these assessments. Staff will be encouraged to attend a refresher at least every 6 months and will receive recognition for doing so. Okay, so as you can see here, overall, I believe the Berwick model worked quite well for this particular case study. The importance that this model placed on the individual patient as well as the defined rules allowed for both patient and parent involvement and advocacy of self, as well as a defined template for creation with specific steps. So those rules that I discussed earlier allowed for a very specific template and for movement of one step to another. So this model, I believe, would be ideal for similar situations in medical centers moving forward. Here's a list of my references throughout the presentation, and thank you so much for your attention.